Now we are move on to the session 4, future radiosurgery. It will be moderated by the Sunil Lee from Inje University and Jun Jo from Konkuk University. Please.
예, 우선 평소에 존경하는 김동규 교수님의 명예로운 퇴직을 축하드리고 외국분도 많으신데 영어로 이야기해야 되는데 제 심정이 잘 전달이 안 될까 봐 한글로 말씀드리겠습니다. 1990년에 저희 나라에 아시아에서 첫 번째로 간만하이프가 도입이 되고 그 뒤로 2년 간격으로 몇 군데 이제 시작을 해서 아주 걸음마 단계에 있을 때 1997년에 김동규 교수님께서 서울대학교에 간만하이프 센터를 설립하시고 참여함으로 해서 우리나라에서의 간만하이프 라디오 서저리의 위상이 굉장히 커졌습니다. 학문적으로는 사이언티픽 백그라운드가 굉장히 강화되었고요. 또 대중적으로는 인지도가 굉장히 올라갔고 국제적으로는 우리나라의 간만하이프 라디오 서저리의 사이언티픽 레벨을 아주 세계 수준으로 끌어올리신 그런 장본인입니다. 저도 평소에는 굉장히 엄하해 보이시고 또 빈틈이 없어 보이셔서 참 다가서기가 어려웠었는데 같이 지내면 지낼수록 따뜻하신 분이고 또 유머러스 하신 분이고 가끔 아재 개그를 하셔서 그러긴 한데 재밌는 분이시고 또 특히 가정적이시고 그래서 멀리서 가까이서 이렇게 늘 이렇게 지켜보면서 배우려고 노력하던 사람 중에 한 사람입니다. 이런 성대로운 자리에서 명예로운 정년을 맞이하신 걸 다시 한번 축하드리고 이런 자리를 준비하신 김성균기 교수님 이하 여러 교직원들에게 경의의 말씀을 올리면서 세션을 진행하도록 하겠습니다. 첫 연자는 제가 소개를 하고 다음 연자는 건국대학 조준 선생님께서 소개를 하시겠습니다. Next topic is volume staged stereotactic radiosurgery for large volume intracranial AVM, progression from theory to practice, presented by Dr. Pollock from United States, Rochester Mayo Clinic. He is a well-known radiosurgeon in the world. When I started radiosurgery, every day I read his article and his paper. Most of the time his life was spent in Pittsburgh. He studied in Pittsburgh, he started his career in Pittsburgh, and then moved to Rochester. Now he's working Mayo Clinic. Please.
Thank you very much, Mr. Chairman. I'm delighted to be here, and it's a great privilege to be asked to speak at this event commemorating Professor Kim's retirement. What I'd like to speak about for the next few minutes is basically a facet of the work I've done on AVM radiosurgery over the past number of years. And so what we're going to talk about is the idea of volume staging large or relatively large AVMs in the hope of increasing our outcomes or bettering our outcomes. So as everyone knows, we probably know as much or more about AVM radiosurgery than anything else within this practice. It's been done for a long time. It was available before the advent of CT and MRI imaging, and for those reasons, we've accumulated a great database on this indication. Basically, the radiation injures the blood vessels, causing an inflammatory response, and as the vessel lumen closes down, eventually the blood flow ceases, and at that point we refer to this as an obliteration, so it's different than a resection or removal, but we refer to this as a radiosurgical cure. When we talk about AVM radiosurgery, basically we think about three things typically. We think about obliteration, we want to get rid of it. We want to minimize the chance of radiation injury, and we want to minimize the chance of future hemorrhage from the arteriovenous malformation. And so if we look back on the work, and much of our basis for this, again, goes back 2 decades or more, we know there's a dose response with AVM radiosurgery and getting an obliteration. It begins to respond probably somewhere in the ballpark of 14 or 15 gray to the edge, and probably reaches a maximum somewhere in the low 20s with an increasing sigmotic curve as you go up in dose. So the question simply would be, why don't we give every patient 25 gray of radiation to obliterate their AVM? Well, the problem is, of course, you end up with an increasing risk of radiation injury. And this is a slide that was put together, or a figure put together years ago by John Flickinger that integrates Gelberg's 3% ISO effect line for 3% risk of radiation necrosis, as well as his linear quadratic formula. And basically, as you go up in volume, essentially you need to go down in dose. And if you basically just extrapolate on this figure, you can see that for larger volume AVMs at about 30 millimeters, you end up somewhere in the ballpark about 14 or 15 gray as a marginal dose that would limit that risk of injury. But we know there's a lot more to radiation injury than radiation necrosis itself. Radiation necrosis, actually a permanent problem that occurs where you see persistent enhancement, often acting like a tumor mass which enlarges, requiring further treatment. But as our imaging got better and we realized the majority of changes that we see are actually just simply increased areas of increased signal on long TR imaging around the irradiated AVM, they're often temporary and they're often asymptomatic. And this makes up the majority of imaging changes that we do see. And once again, going back to work by John Flickinger at Pittsburgh in the mid-90s, essentially you can correlate the chance of getting these T2-based changes on any number of radiation parameters. So 12 gray volume or 10 gray volume correlates with the chance of getting these symptomatic T2 changes, and certainly it correlates to location. So if you look at an early paper looking at LINAC-based radiosurgery from UCSF, essentially, again, single fraction and relatively simple planning and such, but within this group, they had 30 AVMs that were larger than 14 cubic centimeters, so we use that as a parameter of size. And if you look at the patients of that size getting at least 16 gray or more, a dose that would hopefully get rid of them, the chance of getting these symptomatic changes were quite high, and the chance that these people would need to go on to require resection of symptomatic radiation necrosis was really quite high at about 1 in 5. And if we look at their Mayo Clinic experience up until 97 for the patients that had AVMs treated in a single fraction over 14 cubic centimeters, our chance of a permanent problem was also essentially 1 in 3. So certainly an unacceptable risk profile for these patients. So when we think about radiosurgery for AVMs, we basically think about balancing getting rid of these AVMs versus the risk of this radiation-based problems, understanding that likely the risk of bleeding is relatively unchanged or somewhat protected up until the point that you go on to have obliteration. But certainly a lot of things also happened. Besides our knowledge base increasing, our imaging got better, our dose planning software got better, the devices got better. So really trying to compare something done in 1992 using Kula-based planning versus what we do now with Gamma Plan and integrating some sort of axial imaging really isn't quite apples to apples when you think of that. And so based on this long experience, no one really argues that an AVM such as this in the hypothalamus would be an ideal candidate for stereotactic radiosurgery. And even if you take it out to the cortex, despite what many cerebrovascular surgeons will say, an AVM like this, which is a Spetzler-Martin grade 2, there's not a whole lot of AVM surgeons dying to take out 100 of these in a row and show that they have very little or no morbidity. And so again, there's a self-selection typically as we look at the microsurgical literature, in that experienced cerebrovascular neurosurgeons understood which ones they could take out and which ones they couldn't. And so based on that, this was actually from an editorial I wrote a while ago. If you go back and look at sort of the fathers of radiosurgery and the fathers of AVM microsurgery, and you look at the relative numbers of AVMs that they managed over time, and this is just a cumulative thing of a series of things I looked at. I mean, you've got people working in the thousands performing radiosurgery, and most people working in the several hundreds with microsurgery. And so you could argue really that even from the mid-2000s on, that probably radiosurgery was probably the preferred method for most AVMs worldwide rather than microsurgery. But what about something like this? This little guy shows up and he's got this progressive weakness and some headaches, and they image him and he's got this tremendous AVM involving the left side of his brain. It's in deep structures, but it's never bled. And the answer is, what should we do? He's getting progressively worse. And we know based on various models that we've built that the chance that this kid's going to do well is relatively low with single fraction radiosurgery, and the chance of problems is actually relatively high. So how do you manage such an AVM? Well, the radiation-based options for these are several, and most have been tried. Simple fractionated radiation therapy over days or weeks, embolization with the goal of giving you a permanent volume reduction to make the treatment volume smaller, a temporal staging where you treat a relatively large area with a lower dose and then come back at some future point and give it a second gamma knife as needed, or the idea of volume stage radiosurgery are all options. So there really isn't a lot of data when you look at simple fractionation, and the simple answer is it doesn't seem to do much. The bleeding rate just continues, and very few of these AVMs go on to obliteration. There's also not a whole lot of data typically on hypofractionated approaches. This was a paper out of Philadelphia, and you look, almost half of these patients really didn't have big AVMs, and a lot of them actually got embolizations. But when you look at the 5-year follow-up, as they used higher doses, quite a few of them went away, but when you look at the incidence of problems, that also went up quite a bit. So it's hard to interpret that as an effective strategy as well. Embolization, and again, the materials we use as particulates or glue, moving on to onyx, certainly have changed over time. The particulates, by and large, weren't very useful. If you went into glue, you had to take into account the risks or morbidity related with that procedure, and even glue had a recanalization rate that was not insignificant. And so something like this, where this had gone embolization, this was treated, and then a number of years later you have recanalization of a superior component that needed to be treated. And then again, thinking of our newer agents such as onyx, this young lady comes in with this AVM at another center. She undergoes onyx embolization, and you see this cast back here. You also see this cast in this artery, ultimately leading to that stroke. And so she came down to us, and we treated this. I'm not sure that we effectively reduced the volume enough to compensate for the deficits that she received. So we did treat her, and she's gone on to an MRI obliteration, but based on her experience, she will never have an angiogram again. So she'll never go into that category of angiographically cured. And certainly recent papers have been written that try to make sure we're dealing with the same sort of patients using various statistical models such as propensity score analyses. And when you look at embolization and radiosurgery versus radiosurgery alone, at the end of the day, virtually every series that ever looked at this has shown that the patients not having embolizations tend to do better. There's a lot of reasons people will talk about. The dose planning is more difficult. There's a radiation protection from some of the materials. But basically what they're saying is it may simply be that the patients being embolized have more complex angiographic features, and that needs to be looked at or taken into account as you compare these patients in the future. And then here's a paper by Dr. Yamamoto that basically was the idea of, again, intentional two-stage radiosurgery, treating a larger volume at a lower dose, and then coming back and doing a second procedure. And here you see, again, a pretty decent angiographic outcome of 65% over time. But again, the biggest problem being that these patients stay at risk typically over the course of many years in this strategy. And so taking into account the idea that dose fractionation has its issues, that pre-radiosurgical embolization has its issues, Really starting in the early 90s or so, a number of centers started to do the idea of volume staging AVMs in the hope of treating these large volume AVMs. And so really it looks like this. So basically in one procedure, we're treating the medial component of this AVM to about a volume of almost 10 cc's, and then bringing them back a period of time later, treating the lateral component, so that overall, again, an AVM that's in the large size, 18 cc's or so, being completely treated at a dose of 16 gray. So theoretically, by doing this, it allows us to cover the entire nidus at a higher dose while still limiting the radiation exposure to the brain. So the question is, did we really accomplish this or not? And the other thing is the idea that when you think about you're going to irradiate part of it, for a period of time, you're going to have that portion potentially changing and evolving and clamping down, and you may redistribute the blood flow. The idea that a partial treatment may increase the risk of bleeding as you're waiting in these patients. And so there were some experimental models by Dr. Lowe, who is at Berkeley, looking at different flow models and small vessels closing first and large vessels closing first. At the end of the day, the stress typically dropped in all these models over time, but basically when you look at partial irradiation models of these, you could certainly see instances where there were times that the stress being placed on the untreated portion of the AVM would be greater. So does that really matter? Well, again, there's not a lot of data on this. This is an old paper, Dr. Columba, looking at AVM radiosurgery using the LINAC. And basically, when you looked at the hemorrhage risk for partially treated AVMs, the risk of bleeding was actually quite high compared to completely irradiated AVMs. And you see that this risk of bleeding for the period of time in the first couple of years was actually quite a bit higher than one would expect based on the natural history of an AVM. And so that was sort of the basis of this. So the idea was, how do we do this? And so ultimately what we wanted to do was superimpose dose plans done before on our current imaging. We had to correct for differences in head frame placement, and so this is well before gamma plan got to the point that you could do this easily. Certainly the eyeball technique, where you just sort of look at it and say, well, I treated this part first, I'm going to treat this part second, I think was probably the most common approach taken. UCSF actually implanted titanium screws into people's head for a bit, and then would register these fiducial markers on the outside, and then transpose the frame differences in terms of location. What I opted to do was basically use anatomic markers. So I basically just expanded the MR that I was doing, and then I would look at either the AC or PC, potentially the takeoff of the trigeminal nerve, something that's simple to look at and reproducible, and then basically get an X, Y, and Z for treatment number 1, do it again for treatment number 2, and transpose, and ultimately come up with a transformation where you could go back, take those old shots, plug in the new numbers, build a plan, outline the plan, and then start your second plan. So it was rather cumbersome and a pain, and certainly gamma plan evolved and made it much simpler for us. But this is what it looked like in the early days, and certainly this is an AVM no one's going to talk about taking out. And so when we did this, at first, relatively straightforward stuff, but you'll see here as I look at this area that was treated initially, we got really concerned that we were doing something wrong with these transformations, and I'd go back and do it again and do it again. At the end of the day, although sometimes you can't see it by your naked eye, even within the time frame of 3 months or 4 months or 6 months, these AVMs were actually responding and decreasing in size by millimeters, and so that really was what we were seeing in some of these early cases. And so what we did was we looked at our first 10 patients that we had treated using this volume stage technique, and then I went back and basically planned them using a single session and sort of compared the different dosimetric parameters. And what we saw was that the 12 gray volume, being a marker again of predicting radiation-based changes or problems following radiosurgery, clearly was less when we did it in a volume staged approach. And if you look at the non-AVM 12 gray volume, it was even more significant. And so at that point, basically we could say that it was technically possible, and again, this was sort of before gamma plan. We thought we had enough information to say that it reduces the radiation exposure to the adjacent tissues. So the rationale of doing this made sense, but really we had no good data on the real efficacy or success rate of performing this. And so the first paper that was written that looked at this was from Pittsburgh with Dr. Siren, 28 patients. And if you look at the cohort of these patients, I mean, the vast majority of these patients had bad AVMs, stage grade 4, grade 5 AVMs. The majority were treated in 2 stages, but the volumes that you're looking at were over 20 cc's by and large. And so when you look at ultimately the patients with follow-up, their overall obliteration rate was pretty low, being 33%. We still had people bleeding, but certainly we saw that the number of patients for this group requiring steroids or having problems related to radiation-based deficits was less than you would expect. So the conclusion was ultimately that it provided reduction in size, we stabilized them, and the bleeds rates were reduced over time. And so as we look at our practice, and I left Pittsburgh in 1996, came to the Mayo Clinic in 1997, and over that time, we treat a couple of these a year. We've always sort of got 1 or 2 of them in the cooker. They're not that often. They make up about 5% or so of the AVMs that we treat. The vast majority we treat in a single fraction as opposed to a volume staged approach. But there too, when we look at them, the majority of these AVMs are high-grade AVMs. We've gone out as far as 4 stages within our practice with an AVM volume that's almost 25 cubic centimeters, and typically we treat at 15 or 16 gray. And so when we looked at this in more detail for patients treated up to 2012, again, a volume that was over 20 cc's, and our follow-up in this cohort was quite good at over 8 years following their last procedure. And so when I looked at these, really there were sort of 3 groups of patients within this series. You had what was the majority, which is a large volume hemispheric AVM that would make up the majority of these AVMs. We designated a group 2 that were essentially big AVMs in bad places, but they weren't big in a sense of being hemispheric AVMs of 20 cc's or 25 cc's, but a 10 or 12 cc AVM sitting in the thalamus was something that we did a handful of stages on. And then we'll touch on this at the very end, the idea of taking an AVM like this that's sort of small, large, or large, small. It's not really a big AVM, but it's pretty big in the idea of saying, well, we could stage this with the idea of rather than treating at 15 or 16 gray, let's go up to 18 gray in the hope of, again, increasing our obliteration rate. And so we looked at these patients. Ultimately, about half of them went on to an obliteration. We still had bleeding that went on that sort of stabilized over time, and it doesn't appear to be any different than really the natural history. We ended up performing repeat radiosurgery on a portion of those patients, and all of those patients went on to a complete obliteration. So an overall cure rate that was basically 7 out of 10 within this group, and ultimately ended up with only 2 patients ending up with a permanent adverse radiation effect from having undergone stage volume radiosurgery. And so here was a patient, and you'll see a lot of these are young people, and that basically comes down to the idea that we don't see many of these in older patients typically. So a 10-year-old boy was developing some hand weakness. We treated him in 2 stages. A couple years later, certainly the volume is much, much less. Comes back for an angiogram, and he's almost obliterated. He still has this little bit there and a little shunting going on. So we waited a little bit longer still. Brought him back, and again, these are being done under anesthesia. Still had some shunting, so we treated that one area, and he's gone on to a complete obliteration. This is a young girl that simply tripped outside of a bar or a nightclub, hit her head, and was found to have this AVM. She's young in the idea of what should we do with it, so she ultimately went on to a stage volume approach. And as you can see, sort of attacking it from front to back, trying to leave sort of the draining veins as sort of the last portion that we treat. And then here she was a couple years out. She still has a little bit of shunting right off the internal carotid artery. She had a little bit of something coming off the external carotid artery, almost like a dural fistula. So at this point, I think she's about 3 years or so out. We'll probably wait another year or 2 and repeating the angiogram, and hopefully it's gone on to an obliteration. I suspect that it probably will. And then this is the one we started to look at. This little guy comes in, and again, treating him sort of top to bottom, or bottom to top. ultimately covering this thing a total volume of almost 40 cc's. And I just saw him back a few weeks ago, and the deep bad component is essentially now cleared up. He still has some AVM sitting up here in the caudate. He himself looks well, so we're going to probably wait another year. And for my own experience, we've typically moved out most repeat procedures out to year 4 or 5. We don't tend to do them at year 3 anymore. We really push it out to years 4 or 5 to sort of get all the bang for our buck from that first radiation exposure. But I do suspect he's probably going to go on to have repeat radiosurgery here in the next couple years. This young girl looks roughly similar to what I've been showing you, but the one thing that looks a little different, overall you think of this as a relatively compact nidus when you look at most of these angiograms, but when you look at the MRI itself, you see a lot of brain parenchyma within this. Nonetheless, she was getting worse. She was very young. She had never bled. The decision was made to go ahead with this approach, and so we treated her again in 3 sessions, almost 40 cc's. But shortly after we finished up her last session, she began to have problems. And she's certainly been the roughest one we've had, short of, we had one person relatively early, 2 people early that bled and died. But she's been our persistent problem based on radiation. So she went through multiple courses of steroids where she'd be stabilized. We reduced the dose, she went back. No one, of course, wanted to give her Avastin because it's an AVM and not a tumor. So we treated her with hyperbaric oxygen, and eventually we got her through all this. So she's doing relatively well. So here she is at 2.5 years. Certainly the vasculature appears much less, the swelling is much less, but lo and behold, the downside of this approach is, as we always talk about, is you're exposed still to the risk of bleeding. And so she did bleed. She ended up with basically a complete hemiparesis. And so we did end up taking this out, and she is starting to make a recovery from that. So when other people have looked at it more recently, here's Dr. Naj for looking at the Sheffield experience, 84 patients with 4-year follow-up really on 44. Ultimately, again, about 60% of them going on to obliteration, a few people dying from bleeding. But when they looked at the risk of permanent adverse problems from the radiation itself, it was certainly less than their historical controls when they were using single fraction radiation, despite the total volume of these AVMs being quite a bit larger, almost 20 cc's versus 15 cc's. And so they concluded that, again, obliteration and bleed rates are about the same, but that the risk of radiation-based problems appears to be less. Here's a report from UCSF where they looked at what they called their early group versus their later group. And this is this idea of basically taking these moderate large AVMs and breaking them up into multiple sessions. And so again, the volume being treated at early was 15 cubic centimeters versus about 7. They went up on dose to about 17 gray. They used sort of a soft parameter, not just complete obliteration, but saying that if they were smaller, and if they compared those that were responding in terms of a radiographic appearance, not an obliteration itself, clearly the rate was higher for patients being treated in this volume stage fashion where they went up in dose and down in volume. So really, and they really saw no difference in complications despite a numerical difference. Statistically, it wasn't any real change. And so really they thought that the idea that, again, for these AVMs of 10 cc's or 12 cc's or 15 cc's, it would make sense in staging them with the idea of increasing the dose up to 17 or 18 gray. And then here's a paper from last year from Pittsburgh where they basically looked at 60 patients, and ultimately their 5-year obliteration rate was only 25%. But when they looked at an intranidal 20 gray volume, if it was greater than 63%, they said, well, the obliteration rate was higher. So Dr. Kano thought the idea that if you sort of packed more shots within the nidus itself, so you take the 20 gray volume and make it closer to the prescription isodose volume, the likelihood that you'd have better outcomes would be their approach. And so again, this sort of also goes into the idea of sort of volume staging these smaller AVMs relative to what's typically been done. Which puts you in seeing someone like this guy, 14 years old, had a seizure. Overall, his grading scale for his AVM really isn't that bad. So the idea is this something we should volume stage or something treat in a single session? I personally haven't bought in completely to the idea of treating something like this in a staged approach, so I treated it in a single day. He was from Central America and haven't heard from him yet. He's going to come back probably in the next 6 months or so, and I suspect he'll do quite well. The kids tend to do better than adults. And so to overall look at this over time, I think we can say now there's enough experience that we can safely manage patients with large AVMs using a volume staged approach. Certainly it's a lot simpler today than it was 20 years ago when we were trying to do this. I think the concept of breaking these moderate sized AVMs up into smaller treatment volumes and increasing the dose should be studied further. I think we probably do need more data in comparing ultimately the efficacy of a pre-embolization using onyx versus radiosurgery alone is something that needs to be looked at. But typically, there are not many of AVMs like this out there. So the idea of prospective trials really are probably not going to be feasible. Potentially prospective registries using multiple centers might give some information, but there's still going to be selection biases and issues with that technique as well. But certainly there's no question that for something like this, they need to be treated where you can do everything. So when we look at these patients, a consideration of surgical resection, embolization, or radiosurgery, we don't talk much about observation because most people are younger, and we're very skeptical and in fact disbelieving of most of the Aruba data, so we're not going to belabor that. But certainly the idea of sitting down with your partners and deciding what's going to be the best approach for each patient is the way it should be performed. Well, once again, I appreciate the opportunity to speak today. It's been a great privilege, and I thank you very much.
Thank you very much, Dr. Pollock, for your detailed literature review and valuable your data. Is there any comment or question about these topics? Professor Lee.
Thank you very much for a nice presentation. A couple of years ago, I investigated the treatment pattern of AVM in Korea, and surprisingly, I discovered that almost 70% of the AVM diagnosed in Korea were treated with gamma knife, and microsurgery or embolization was performed only in 30%. So could you tell us the trend in United States?
I think this old slide I made years ago when I was asked to talk about the relative roles of microsurgery and radiosurgery, I think that's been the trend for a long period of time. And it's not to say that we don't have experts in cerebrovascular neurosurgery that can safely take out AVMs that they know that they can safely take out. But the smart surgeons for AVMs that hadn't bleed had learned that it's better often to push this off and perform radiosurgery. And so I don't think there's any great numbers to use within the United States, but certainly more than half of the AVMs undergo radiosurgery. I think if you look at unruptured AVMs, it's probably much closer to 80% or more.
Thank you, Bruce, for your great presentation. And I have one question. You explained the efficacy of volume stage radiosurgery for large AVM. Could you comment some your opinion about the time staged and some hyperfractionated gamma knife radiosurgery, as you mentioned at the first slide, about to treat large volume AVM?
Again, there's not a great deal of data out there looking at hypofractionation. Again, most of it has been done using linear accelerators. The dose planning I don't think was that good. That too is another opportunity to potentially look at the success or treatment efficacy of that approach versus, again, embolization or this volume staging approach. But the problem is, because the numbers for all these things tend to be small, we have local prejudices. So Pittsburgh and Mayo may do it this way, and UCSF may do it this way, and Stanford will do it this way, and Seoul National will do it this way. So it's really hard. So again, I think trying to use better statistical methods for registries is really all we have left. But you're still left with trying to truly mix the same groups of patients for the different treatments being offered.
Yep. What I'm asking you is that based on the radiation biology of the radiosurgery, so what's your opinion about the preference of volume staged versus time staged or hyperfractionate?
I mean, if you think of time stage in a sense of treating a large volume once and then seeing what happens over time and then doing a repeat procedure sort of as a planned approach, is that what you're referring to? Or doing a series of doses, the first one? I don't think it's unsafe. Like, the question becomes, at what point do you draw the line with an AVM that isn't 15 or 18 cubic centimeters, but 30 cubic centimeters or 35 or 40? I mean, do you give 12 gray at that first session, knowing that the relative efficacy is very low, and will you get volume reduction? And certainly, again, when we look at bleeding after AVM radiosurgery, there appears to be a correlation with volume, that the bigger ones tend to stick around longer, so they tend to bleed more. So then you're increasing that latency interval with that approach relative to potentially, again, an embolization and or a staging. But it's just something I don't think there's a great deal of data out there. I think, again, I think that last one that I showed, I have no doubt if they were treated in Pittsburgh probably today or in San Francisco, they would have taken this young guy and broken it up into 2 6 or 7 cubic centimeter treatments. I think that's almost certainly what they would have done. I personally haven't been won over completely. So for that volume range of 12 or 14 or something that's in the cerebral hemispheres and not deep, we would certainly treat it, especially in the kids, at 15 gray probably, with the idea that likely it would respond, and if it doesn't, we can come back and do a repeat procedure later.
Thank you.
I have one more question. I think the meaning of remained or residual or partially treated AVM is some different from as compared to neoplastic lesion. So how do you do for the patient who have a residual or incomplete lesion of large AVM after volume staged radiosurgery? And how different the prognosis of the natural history of large AVM and partially treated small residual AVM?
I mean, the majority of people, if they've not had a radiation problem and they've not hemorrhaged and they come back and they have a residual AVM at 4 or 5 years, most of them have gone on to have a repeat treatment. And then again, it's a little different than a planned approach, but we repeat the treatment. Certainly, again, UCSF has spoken extensively about the idea that, and Stanford as well, the idea of using radiosurgery as like an embolization, that it makes it simpler to remove them later. So again, if you had an AVM that was reduced in volume, it still came to a surface and was relatively simple to tackle, certainly the option to remove it at that point, I think, exists, and likely the morbidity would be much less. So within our practice, again, if they haven't hemorrhaged and they still have residual, and we think they have enough life expectancy that it's worth doing, we typically would offer a repeat procedure. But if they hemorrhage, then almost always, if they're well, we would take it out.
Okay, thank you very much. Next, the plate of appreciation will be presented by Department Chairman Professor Kim Seung-gi.
letter of appreciation, the organizing committee is pleased to present this certificate to Professor Bruce E. Pollock in recognition of his outstanding lecture. 승기 Kim, Chairman, Department of Neurosurgery.